Hi, good afternoon. Thanks all for being here. I'm honored to be part of this today. My name is Marisa Savasco. I'm one of the heart surgeons at Penn, and welcome to the Abiomed lunch. And I have a great panel with me today. So like I said, I'm one of the cardiac surgeons at Penn, and I also have with me today Dr. Danny Goldstein. And Dr. Goldstein is the professor and vice chair of the Department of Cardiothoracic Surgery at Montefiore, and he's also the surgical director of the Mechanical Assist and Transplant Programs. Welcome to Dr. Goldstein. Dr. Soltesz is joining us from Cleveland Clinic, where he is the surgical director of the Kaufman Center for Heart Failure and Recovery. And then Dr. Reddy is the chief of cardiac surgery at TriStar Centennial Health in Nashville, and he's also on the executive board. He's an executive board member of ERAS. So I'm just going to start off with a brief introduction, and then I'll let the experts take it away. So our overall topic, our overall agenda today. So Dr. Goldstein will talk about the IMPACT trial synopsis, get everyone up to speed on that. And then we'll turn it over to Dr. Soltesz, when he will describe how he uses the Impella 5.5 to deal with mechanical complications of MI. And then finally, we'll talk to Dr. Reddy, and he'll give us his perspective on using the Impella 5.5 for enhanced recovery pathways. So just a few background slides. So this first slide shows the overall kind of monthly volumes of Impella 5.5 since its launch. So you can see here that the device was launched in 2019, and the adoption curve has been pretty steep. There's a little bit of a seasonality to it, but monthly volumes, new implants are around 500. So this is something very interesting. Now, my hospital, we didn't get the device till 2021, so we had the 5.0 for 2 years after the 5.5 was launched, and so that was, I think, part of it too. But overall, here is the overall adoption curve. Now, this is total implants globally. So the prior slide was just U.S. Monthly volumes, and then this is the overall overall global adoption curve. So up to 15,000 patients have been supported by the 5.5. Dr. Ewan Wang in Florida, another great cardiac surgeon who's very familiar with the device, he put in the 15,000th device. So how do I use the 5.5? Well, I do a lot of LVAD surgery, heart transplant. We have a big shock center at Penn. And I also use it in patients after CABG or for high-risk valve surgery, people with biventricular dysfunction. So very sick patients, and they need support, and we want to decrease that early morbidity of the first 48 hours after bypass. But specifically here, I just pulled a couple slides for those of you who were in the main session earlier, specifically about CABG. So, high-risk CABG patients, that surgery is not going to go away. So patients with low EF, we know that there's a benefit to CABG over medical therapy in patients with low EF. STITCH trial, I think everyone in the room is familiar with it. We know that CABG yields a 21% reduction in deaths from cardiovascular causes versus optimal medical therapy alone. And you can see here as the curves digress further out, that's where we see the advantage over time, so long-term follow-up. But the red circle there in the beginning of the chart, you can see that's the highest risk right there. That's the highest surgical risk. So there's an upfront surgical risk. And how can we mitigate that upfront surgical risk? So a little bit more about this risk. My former colleague when I was at Columbia, Dr. Veli Tapkara, 2005 publication that's from Circulation, he looked at 55,000 patients from the New York State database. And he stratified these patients into 5 different categories based on their EF. So he included patients who underwent off-pump. So these were all CABG patients, all comers, and stratified into 4 different EF groups. And you can see the red arrow is pointing out that the low EF patients had the highest in-hospital and early mortality. So around 4 times those of relatively normal EF patients. Another study, this time from the STS database, Dave Shahian. This looked at 750,000 CABG patients. This was a study that was done from 2002 to 2006. Again, arrows highlighting the mortality within 30 days. Around 10% of CABG patients have an EF of under 35%. Patients with an EF under 25% have in this study, showed around a 7% risk of early mortality. And then 25 to 34% EF, you still are around a 5% mortality. So those 10% of patients represent a disproportionate risk of mortality. And that's still, in this study, that was around 4,300 patients. That's a lot of patients that potentially we could have avoided having an adverse outcome. So who would benefit from post-cardiotomy temporary mechanical support? So we do know some of the characteristics of patients who would benefit. So as you saw in the previous slides, those patients going into the OR with low EF. Anybody with EF under 25, even 35%, we see that there's a benefit to upfront mechanical support. And a lot of these other risk factors are intuitive to all the surgeons in the room and anyone taking care of these patients. Doing an urgent or an emergent CABG, they're going to have a potential high risk for post-cardiotomy shock, a low index going in. If you have end organ dysfunction, if patients are going in with an AKI or their transaminitis, they're at a higher risk. This phenotype of diabetes and kidney disease, they can struggle post-op. Poor coronary targets leading to incomplete revascularization can be problematic. And then just your typical high-risk other characteristics, prior radiation, RV dysfunction, concomitant valvular procedures, anything that will add to your bypass time. So many of you are also familiar with the Impella family of devices at this point, but just as a refresher, the Impella is a microaxial surgically implanted heart pump, the 5.5 specifically, via the axillary or a graft on the aorta. It unloads the left ventricle. It reduces ventricular work. It allows for early ambulation, early extubation. It has a great hemocompatibility profile. And again, it avoids these femoral access issues, leg ischemia, problems with embolization, having to cut down on the groin to take it out. I really like this study that Naveen Kapoor did out of Tufts. So this was a patient who ultimately went a heart transplant, but he put a conductance catheter into the LV and into the RV of this patient. And so he actually just generated pressure volume loops from a patient. And you can see that not only is the device improving the hemodynamics, the ventricular work by the LV, but also it improves the RV. So I think we're not just seeing LV unloading. I think there's a benefit that the RV is gaining as well. And there might be some cardiorenal access protection that is also afforded from this device. So I think there's more to come on unloading the effect of the Impella on the RV as well. There's been a lot of studies, a lot of single-center studies, even dating back to 2013, when the earlier generation of devices came out. This is a more recent run from 2019, but again, on the earlier generation of devices, Dean Smith at NYU. Single-center study, 13 patients. They decided that they would use an Impella to decrease the risk of post-cardiotomy shock. They used both the 5.0 and the direct device, placed either via the axillary or directly through the aorta, depending on the device. And this was a planned upfront support for a patient. They did not want to attempt to wean and then have the patient go into shock. They didn't want to have a delayed implantation. The patient population was on average, had an STS score of around 5%, and the EF was around 20, so 19.6%. They had great results. There was a very low rate of renal failure, which contributes a lot to postoperative morbidity and mortality. And there was zero mortality in this patient population. I do want to bring up, and Dr. Soltesz will tell us a little bit more about this as well, but the Cleveland Clinic approach to high-risk CABG using the Impella. So they describe an approach, and they become very facile with it. They have a systematic, programmatic approach to taking care of these high-risk patients in order to have patients keep their own native hearts, revascularize them, instead of necessarily some of these patients would have otherwise been sent to heart replacement therapies like transplant or VAD. Not everyone will qualify for a transplant, and not everybody wants a VAD. So if we can revascularize these high-risk patients, get them safely through the surgery, avoid the high-dose inotropes post-op, minimize that vasoactive inotrope score, then we can get these patients safely through the operation. So that's all I have, and I wanted to turn it over to Dr. Goldstein. And Dr. Goldstein and Dr. Soltesz are both co-PIs of the Impella Protected Cardiac Surgery Trial, otherwise known as the IMPACT trial.
Thank you, Marissa. It's always challenging to speak at lunch because you have to make your slides more interesting than your sandwiches. And then you have to deal with the postprandial lethargy that follows. So thank you again, Abiomed, for this opportunity. And basically, my task is to provide you a summary of the rationale and design of the IMPACT trial, which is a study that's being conducted in the US and separately in Germany that seeks to investigate the potential role of the 5.5 device in high-risk patients undergoing conventional adult cardiac surgery. So I think most of you in the audience know the Impella 5.5 device is a transvalvular device that profoundly unloads the dysfunctional left ventricle and sustains systemic perfusion, and can be inserted peripherally from an axillary artery like you see in the bottom, or directly through the aorta, or even the innominate artery as you see on the top. The pump has been used in patients who are awaiting transplantation but who decompensate before an organ becomes available. It has also been used in patients who undergo an ECMO support as a transition platform that continues to provide systemic perfusion but also unloads the left ventricle, while allowing for ambulation and reconditioning. It allows to assess the function of the right ventricle. It's a sort of very interesting concept. If you're thinking of putting a durable LVAD, you're not sure how the right ventricle will behave. You have the Impella 5.5 as sort of a trial run. And importantly, it allows you to complete the transplant and LVAD evaluation, which sometimes are quite lengthy. Imagine getting a colonoscopy on ECMO, peripheral ECMO, is much harder than an ambulatory patient. So a lot of rationale for using this technology to transition off ECMO, and our practice in general is anybody who goes on ECMO, if they wake up and they don't need their lungs, they go on to a 5.5 fairly quickly. The technology has also been used as post-cardiotomy shock, as Marissa showed you, and it's been used in patients who have received an Impella CP in the setting of an acute myocardiogenic shock, but continue to deteriorate hemodynamically and require additional support. So 5.5 has been approved for all these shock indications, and it can be effectively used to bridge to transplant, to durable technology, which right now there's a one-only device, to recovery, which is a whole, this device has sort of created a paradigm shift in heart surgery in general, because we never used to speak about recovery, because you need to have really good technology to facilitate recovery. And for those of you who go to ICLT, the big heart-lung transplant meeting, so it was always about LVAD and transplants. And now, so there's a third shelf now, and that's the issue of recovery. So it's been used in all these shock scenarios, and it's approved for that indication. Now, there's been anecdotal reports, and Marissa showed you one from NYU. That's the only one, actually, that has more than a couple of patients. They have described the prophylactic use of this technology, sort of preemptively, in the setting of high-risk surgery as a way of mitigating what? Well, you want to prevent post-cardiotomy shock. And addressing these potential indications is really the goal of the IMPACT trial. Now, there are several truisms, if you will, regarding high-risk cardiac surgery. First, close to 15% of all cardiac surgeries are on patients with ejection fraction less than 35%. That's about 20 to 25,000 patients in the United States per year. Secondly, and Marissa just showed you this, several studies have shown that low EF is associated with worse outcomes, both mortality and morbidities. Third, and this is up to today in every country that does cardiac surgery, the current standard of care is vasoactive medications, and if you're going to use MCS, it's a balloon pump. And we also know that these strategies associated with higher risk complications, suggesting that perhaps better options are needed. So now, all the data on this slide, and most of the slides that Marissa showed you, if you paid attention carefully to the references, they're all at least 10 years old. So they don't reflect advances in anesthesia, surgical and critical care, and the availability of newer technologies like the Impella 5.5. So with that in mind, I'm going to share with you some data that will be submitted for publication, and it comprises the largest contemporary study ever looking at outcomes of post-cardiotomic shock in patients with low EF, so severe systolic left ventricular dysfunction, EF less than 35%. Now, this data you see here in the table was extracted from the STS registry, and it includes all patients who have undergone CABG or CABG and mitral valve surgery, repair or replacement, in the setting of an EF of less than 35% for 2 years, 2018 and 2019. Why did we choose those years? We didn't want to deal with what happened in the pandemic because everything was screwed up. So those are the latest years in terms of getting contemporary data. What you can readily observe that in both the CABG and the CABG mitral groups, post-cardiotomy shock is associated with a dramatic increase in mortality and in all other significant morbidities that we worry about: stroke, prolonged ventilation, renal failure, return for bleeding, and even a higher risk of 30-day readmission. So this is compelling data. Now, if you look at 30-day outcomes, stratify whether the MCS was initiated at all and the time of initiation for those who get some temporary MCS, a very interesting pattern emerges. If you look at mortality, in this cohort, 2 observations can be made. First, patients who received temporary MCS had higher predicted risk of mortality. That's the white bars. And that makes sense. If you're sicker, your surgeon is more likely to put a device in at some point. So that's number one. Number two is that while the predictive risk of mortality was similar among all the patients who had a device placed, those who received it earlier, meaning pre-op or preemptively, had a much lower mortality. And that's what you see in those other dark bars there. Now, if we look at the morbidities, and again, these are the things that we worry about besides death: stroke, prolonged ventilation, renal failure, PCCS, post-coronary shock, and atrial fibrillation. Preoperative or preemptive insertion of support was associated with lower risk of any and all comorbidities when compared to later institution of temporary mechanical support. So clearly this data is, is derived from a registry, so it suffers from the limitations that any registry has, like lack of granularity and patient-level data, and includes different modalities of temporary mechanical support. Therefore, the conclusions that we can derive from this is limited. However, the suggestion that timing of deployment of support can impact outcomes is hypothesis generating. It's frankly very exciting, and is really the impetus that drove the IMPACT trial. So the purpose of the trial was, it's an ID trial, to demonstrate the safety and effectiveness of the Impella 5.5 in high-risk adult cardiac surgery. The overall aim was to see if this technology, combined with Smart Assist, used preemptively, improves early hemodynamics and organ function and clinical outcomes in patients with EFs less than 35%. The trial is designed as a multi-center, prospective, single-arm trial. So it's an observational trial. Every patient is going to get a device, and they're all going to get it before we separate from cardiopulmonary bypass. There's no, let's see how he does with a little milrinone and vasopressin. No, everybody gets the technology first, then you wean, and then you use whatever you need to use. There's 15 US sites. As I told you, there's a separate German study with, I believe, 10 sites, and they're a little bit ahead of us. We just launched a trial here in the United States. Importantly, there's a concurrent registry that's going to collect data on patients who were not approached for enrollment for one reason or another, or who were enrolled but then did not meet criteria. And we're hoping to capture 500 registry patients, which will help us as a comparator to the trial patients. So the primary endpoints of the slide, shown in the slide, there's a safety endpoint, which is a 90-day composite of all-cause mortality, stroke, and needing dialysis, new requirement for dialysis. And an effectiveness endpoint, clearly, I told you, what is the goal of this technology, using this technology in this way, is to prevent post-cardiotomy shock. So how do we define post-cardiotomy shock? And it's variably defined in the literature, but here is needing an RVAD, ECMO, LVAD, or transplant during your ICU stay. That makes sense, right? The LVAD supporting the LV. If you have severe RV failure, you need an RVAD, boom, that's a strike. Or if you've left the ICU, but then you have to return to a high level of care because you're in low cardiac output, and we essentially mandating a SWAN. And you either need vasopressors, and you see the criteria here, or you need any MCS at all. So that's a strike. The inclusion criteria are stated here. They're going to be modified soon. But it's basically any patient with any combination of coronary bypass surgery, mitral valve, and tricuspid valve. You can add an AFib ablation procedure in there if you want, a PFO procedure if you want. That's how it stands now. We're going to be adding an AVR as well. There was some discussion among the investigators whether we feel comfortable putting an Impella 5.5 through a new valve, and we all decided that we are. So that's going to increase our ability to recruit patients. The ejection fraction criteria you see here, ejection fraction less than 30% for CABG patients, and less than 35 for people who have mitral regurgitation, who you're going to fix. So meaning 3+ or 4+ MR. There are adults and the usual other constraints of any trial. So in summary, the trial, which is really three things, it's Impact US, Impact Germany, and the parallel registry, will allow us to understand what phenotype of patients surgeons think are high risk enough that you are going to invest the time and the effort in using this technology. They may identify, and I hope it does, identify a cohort of patients who are too sick even for 5.5 support. Or patients that are too well. You know, an EF of 25% in a CABG patient who has a tight LAD and a hypokinetic anterior wall with good other targets and, you know, creatinine 1.4, that combination probably doesn't need it, right? You need nothing. Might have a little butamine, at worst a balloon pump. So I think this trial is going to sort of help us figure that out, because there's just no literature on how the few people who are using this device in that setting are doing it. And it may allow us to develop best practices for deployment of intraoperative 5.5 support. Do we use this, or do we go direct in the aorta? What works better? As well, anticoagulation management and weaning strategies. And importantly, it'll hope to inform the ultimate goal, right, which is a randomized trial where you randomize 5.5 versus standard of care. So I think that concludes my talk. I think we're going to stop here, open it up for some questions from the audience, if you're not too tired from your sandwiches.
Are there any questions from the audience? Well, if not, I have a couple of questions, or if anyone from the panel can also chime in. So just in terms of the design of the study, could you just explain a little bit how you chose single center versus a randomized control trial? Will there be a role for that in the future? And then the EF percentages that were chosen, 30 and 35, just could you give us a little light on that?
Sure, so Ed will confirm this. It took us about 1.5 years to realize we could not do a randomized clinical trial. The protocol development of this trial took about 2.5 years. Some of it was COVID related, but some of it was, we was really struggling with, do we do a randomized clinical trial that everybody wants to see best evidence data? The problem is there's no literature on how we are using this technology, right? Does show of hands, does anybody use this technology as I've described? Any surgeons in the audience? Preemptive use, nobody. Oh, one surgeon. We do. You do? We actually do. Can you come to the microphone?
Yeah, sure.
Thank you.
So, Alexander Assmann from Düsseldorf, Germany. Thank you very much for this tremendous presentation, for bringing up and pushing forward this trial. We are also taking part in the Impact German trial. And I personally favor Impella OpCap. It's a great approach. On the one side, as you said, preemptive MCS for the post-operative period, but you were also talking about minimizing the intraoperative risk, and I think the combination of Impella already done for the intraoperative use is an additional aspect to reduce the risk of the operation itself. And then you have this great approach that you can bridge the inflammation afterwards by just leaving the Impella for 3 to 5 days on the intensive care unit. So it's a great approach in my opinion.
Yeah. So the Germans have always been ahead of us in terms of everything. I mean, there's someone said if you think you invented somebody, look at the German literature, because they've invented it first. And Germany has always been very pro-MCS. They don't use inotropes. If you think about it, you just operated a sick heart, and you want to beat it up with more inotropes. That's not what you want to do. You want to rest it. And they've always been, before it was MCS, now you're getting more aggressive with Impella. It's a good idea. But nonetheless, so I go back. the question, why not an RCT? Because we just don't know what kind of patient we would put in the RCT because we don't understand how this device is used in this setting. So I think that's what the trial is going to inform. Who's too sick, who's not sick enough, sort of what comorbidity burden is going to be okay in order for people to be comfortable randomizing to a balloon pump, inotropes, or tandem, or something else versus Impella 5.5. So that's the main reason. In terms of the category ejection fraction, we chose EF of 30%. Some might say, well, that's too high. I'm not going to put it. We want it to be broad enough so that we don't restrict enrollment. Every trial has to enroll. And that'll play out. Surgeons are going to decide, maybe we'll see that everybody has an EF less than 20%. So the option is there, and you're going to use it however you want in the kind of patient. For MR, obviously 35%, you want to shoot higher because someone who has an EF of 35% with severe MR, the true EF is much lower, right? Once you shut off the pop-off valve, the left ventricle does not like that, and so those are the two reasons.
Okay, that's fantastic. Just one quick question, Al. I'm going to take advantage of you being at the podium and gain from your expertise. Your preferred approach, do you do axillary, aorta, kind of depends? What's your default method of
It has been axillary in the past, and again, the trial is going to show what people are more comfortable with. There's some logistic issues on the trial. If you're going to do it axillary, well, do you put a wire, do you do all the fluoro stuff beforehand and then open the chest, or do you open the chest and then do this? You need fluoro, so everybody has to put the lead on, and then everybody has to take the lead off. So there's a lot of logistic issues that we're working. Part of the trial, the reason for the trial as well. With the aortic, you don't have to do anything. You can just sew the graft on, do your operation, and then just pass. You can do it with echo guidance. You don't need a fluoroscopy. So there's with this, obviously, this taking out, it might be easier than taking this out afterwards. So there's plus and minuses to each way. I think Ed has been a proposal of the axillary approach. There's others that are just aortic. I haven't decided yet. I think it probably is situation based. So, Ed, you want to comment on that? Why one or the other?
Yeah, I mean, I think it depends on what you're comfortable with. I think we're going to learn, obviously, with the trial what may be preferred in various different situations, but I think you'll realize that there are advantages and disadvantages of each. So there's certainly, we all recognize that patient who's got a small, short aorta, ascending aorta, not a lot of room for cross-clamp cannulation, grafts, et cetera. Whereas, when you start to dig out an axillary in someone with a BMI of 45, that's a challenge. And so again, I think we'll learn some more of this as the trial progresses.
How are the Germans doing it?
Axillary approach. I mean, the great advantage of the axillary approach is that at explantation of the pump, you can get rid of the graft. It's quite easy. You don't have to go for resternotomy. You won't leave the graft inside. It's just less foreign material in the patient. Yeah.
Most of the people doing aortic are coming out, I think, supraclavicular, so I've done it. So you don't have a lot of graft left after, but yeah, you have more graft than you have. You can't put a clamp on it. There's all the issues, when you tie the Impella 5.5, you're mandating clot's going to form there, right? Between the suture and the vessel. And there's concern about when you pull that thing out, what's going to happen. And we have to figure that out. Is there a difference between pulling it out of the aorta, pulling it out of the axillary? I think the price you pay if you have an embolization from here might be higher than the price you pay here. Here you can put Bessie loops, right, and occlude it while you take it out. You have no control here. So there's all these issues that we have to work out that we felt that a observational trial was necessary first.
Excellent. This is fantastic insight. Thank you so much. Dr. Soltesz will now be discussing acute MCS for complications of MI.
Well, thanks. And we're at the International Coronary Conference because we all like coronary bypass operations, but unfortunately not all of us enjoy post-MI ventricular septal ruptures or other mechanical complications. So I'm going to be talking about something that not all of us necessarily enjoy. I know my colleague, Dr. Bakeen, in the corner there, has a nice cabbage ceramic pot in his office. He doesn't have a ceramic block of Swiss cheese, but I'm going to be talking about Swiss cheese. So here are my disclosures. So the incidence of mechanical complications of MI, if you look at it over the past 15 years, it's relatively flat. There was a bit of an increase, which is not displayed here during COVID, obviously because of delay of presentation of MI. But for the most part, the institution of strict door-to-balloon time management has mitigated some of this. But unfortunately, the mortality of these complications, being whether it be ventricular septal rupture or papillary muscle rupture, is quite high. It's about a 40% mortality across the board. So there still is a lot to learn and a lot of opportunity for us in managing these patients. So let's frame our discussion over the next 10 minutes or so with the case. This is a patient who came to us about a year ago, 70-year-old gentleman with angina and dyspnea for about a week. This is just sort of in the time of the end of COVID, per se. And he had dyspnea and angina for a week at an outside hospital in West Virginia. And I'll show you the left heart cath here in a second, showing a total occlusion of the LAD after the first diagonal and some disease in the right coronary artery. The patient underwent a successful PCI to the LAD, and a balloon pump was put in. Here you can see the cath, and focusing on obviously the problem on the right there with the LAD taken out. Here they get good access and what appears to be, at least from my perspective, good flow and good revascularization here. But unfortunately, the patient developed hypoxia and holosystolic murmur shortly after the PCI. They appropriately had a swan in place, and you can see the patient's in cardiogenic shock, wedge pressure is high, and all the other indices of end organ function started to deteriorate. So the patient was transferred to the Cleveland Clinic at that point in the context of significant pulmonary overcirculation, cardiogenic shock, and end organ dysfunction. And our echocardiogram at the bedside showed a large anterior apical post-MI VSD with a significant visual left to right shunt. And at that point, we called our shock team, and it called at 2 in the morning. Of course, all these transfers seem to come at 2 in the morning, and we always seem to be woken up by shock calls at 2 in the morning. I wish they would come at 2 in the afternoon, but nonetheless, that's when they come. But I think the key part here is and I think a lot of you have shock teams at your institutions, and that is to understand what a shock team can add. The multidisciplinary advantages of a shock team are tremendous. So the keys to having a shock team are not just to have a group of people to come together and talk, but actually to have developed a vision, a strategy, and tactics. Our vision for our shock team that we developed 5 years ago was we want to improve survival in cardiogenic shock patients. Our strategy was threefold, and we have defined this and we have reiterated this to all members of the shock team. So anyone, our residents, our fellows, our staff know the tripartite strategy. That is, we want to have support, temporary mechanical support for patients who need it in cardiogenic shock that is ventricular specific, unloading, and ambulatory. Those are the three characteristics of our strategy. And our tactics are various different types of devices we use. We're not one device type of program or another. So we use all devices. The key, however, is the concept of ventricular unloading. I can't overestimate that, because basically when you have an unloading of the left ventricle, as you can see here with the Impella device across the aortic valve, you decrease left ventricular end diastolic pressure, you decrease left atrial pressure, and in the process, you're significantly reducing right ventricular afterload. So a univentricular left-sided support device is also significantly helping the right ventricle. And that's why we can get away most of the time, 95% of the time in our hands at least, with a univentricular left-sided support device that is unloading. And we don't need true biventricular support. And we understand this. If you put in LVADs, you understand that too, why you can put in an LVAD in someone with true biventricular heart failure and get away with it. Now, of course, there is the phenotype of right-sided heart failure, and we see that, and those patients certainly may need biventricular mechanical support. But for the most part, we're able to accomplish our unloading and our advantageous circulatory support with a single-sided device. So we call it our tailored shock strategy, and what that means is that we realize that there's no one single device that fits every single patient, nor every single continuum in cardiogenic shock. So we switch devices many times. And our switching of devices, our goal, our holy grail, so to speak, is that tripartite strategy. We want to get to a mechanical support strategy that is ventricular unloading, ventricular specific, and ambulatory. That's what we want to get to. We may not start there, though. So in this patient, if we have cardiogenic shock with cardiopulmonary collapse, as we have in the case we're discussing, the shock team gets activated. Oftentimes, in this situation, we cannulate the patient percutaneously for VA ECMO. We always use a reperfusion sheath and spectroscopic limb monitoring. But within 12 to 48 hours, we are doing something called device tailoring. Device tailoring is a way for us to take the patient to the operating room with no preconceived notion of what we're going to do. But we want to understand at that point what part of the heart needs support, how long do we need support, and how much support is needed. And that will define what our next strategy is. Sometimes we can completely decannulate from ECMO. Sometimes we need biventricular support. But the majority of times, 95% of the times, as I said, we can get away with implanting an axillary 5.5 Impella, decannulating VA ECMO, and supporting the patient on a univentricular left-sided support. 95% of the time. So when we go back to our case, this patient with acute VSR was cannulated for VA ECMO emergently in the ICU by our fellows at 2 in the morning. The balloon pump was left in place that had come from the outside hospital. It was non-pulsatile with the balloon pump. So we're left with some options now, right? We have a patient with an acute complication of an MI. Do we take the patient the next day or the day after for emergency VSD repair? Do we continue VA ECMO and maybe 3 or 4 days? Allow the patient to remain supine, intubated, not moving, and then do a semi-urgent repair? Do we tailor our MCS strategy, as I had said, to a ventricular-specific unloading ambulatory platform like the axillary 5.5 Impella? Or do we say, forget it, we're going to toss the heart in the bucket and put in a total artificial heart? So that's what we have been tasked with trying to figure out is best for this patient. So the traditional paradigm, of course, with acute surgery for post-infarct VSR was quite high risk. We know that. That's reflected in some of the numbers I had shown before. And part of this is because there was no good non-sternotomy temporary MCS platform to bridge these patients. If we took them right to the operating room and put in an LVAD and repaired the VSR, that was also high risk because the repair was unstable. It was sort of a mushy myocardium, small LV cavity, sometimes continuing to infarct the myocardium, and persistent end organ dysfunction at that point left these patients with a high mortality rate. And of course, if you pursue a total artificial heart, you're obligating that patient to a transplant. So we shifted our paradigm 5 years ago, and it was sort of just before the pandemic, to using transvalvular microaxillary support to provide bridging for patients with VSDs. That would allow organ recovery. It would mature the infarct, and it would give us some time to understand ventricular recovery, because not every single patient will benefit from primary repair. Sometimes there's too much myocardium that has been sacrificed. So if you look at it this way, we have a patient like ours who is a post-infarct VSR with shock. Of course, we go down the shock pathway. We eventually come to the unloading strategy with the right axillary Impella 5.5, but we use that strategy for 7 to 21 days, at least in our hands, and then proceed with definitive therapy. Definitive therapy being either primary repair, potentially continuing postoperative temporary mechanical support in some situations. Some patients underwent primary repair with an LVAD when we felt that there was too much myocardium that was destroyed, and a few others had gotten transplants. There was a few patients, of course, we've discovered along the way were palliative, because mainly their family and them did not want to pursue further options. So our goals really are to make the case elective, and you can see here on the left the myocardium that you look at when you're repairing this operation the next day in the operating room versus what it looks like 14 days of unloading. It's a dramatic difference. And really, during that time frame, it's not only maturing the myocardium, it is also decreasing pulmonary overcirculation, recovering end organ dysfunction, washing out antiplatelets, because the majority of these people have had a PCI, and really mobilizing the patient. You'll hear more from Sinu about ERAS and some of the recommendations therein. So back to this patient, we tailored our mechanical support after 12 hours of ECMO. We put in an axillary 5.5, removed ECMO, the balloon pump. The patient was extubated. About 12 hours later, you can see here on the left the tip of the impella that is obviously quite high above the apical VSD. We've used these in all VSDs, whether it be posterior basal or anterior apical. Now you may ask, well, what about reversing the shunt? Would you basically suck blood across the VSD from the right to left side and become hypoxic? That doesn't happen. It hasn't happened. And that is what we would call an old wives' tale or an old surgeon's tale. So if you look over here, look at the pre-impella hemodynamics, you can appreciate the shunt fraction of 2.3. With the 5.5 in place, the shunt fraction drops. Not always to 1.5, but to a degree that is much more conducive to recovery. And notice the significant decrease in wedge pressure. Now, at the same time, you are allowing the patient to ambulate too with this platform and end organ to recover. I would always mention that there is the potential need for right ventricular support in these patients. It's rare, as I had mentioned before, but you have to recognize when you need it. And I think it's important to see that, especially looking at some of the hemodynamics, because with the Swan-Ganz catheter in place, you are, and with the VSR, it's very easy to understand when you'll need right ventricular support. So in this patient, unfortunately, the anterior wall had extensive damage, and we went forward with a repair and a DT LVAD. Patient was discharged 12 days post LVAD implant, obviously in much better shape than they came, and they're actually on the transplant list as we speak. But the key, I think, is to understand the physiology. And this was a great paper by Burkhoff's group utilizing a validated cardiovascular model, looking at the different types of support in these patients and recognizing that the sweet spot, so to speak, is a transvalvular axial flow pump like the Impella with univentricular left-sided support. I think Impella is potentially overkill in these patients. But I think what we've recognized is some of the worries we've had with this support really do not come to pass. We have now done it. This is a little bit outdated. We've now done 25 patients with support. 2 patients died. Both of them were very early on from multi-organ failure, and over 85% of them underwent definitive surgical repair. The other 15%, 2 of them underwent transplant to LVAD. So I think this is a new paradigm that we and others have certainly found great success with. This is what it looks like after 18 days of Impella support. I mean, that looks like a primary VSD, not a post-infarct VSR. So I think modern-day temporary MCS should be considered for stabilizing such patients as a bridge to definitive repair. Ideally, definitive repair in this group is the best if the myocardium can support repair. Obviously, we want to convert what was historically a surgical emergency into a time-delayed elective surgical repair. And lastly, I think as we gain some data on this over the next few years at conferences like this as well as others, we'll be able to socialize some of these results. So thanks very much for listening.
Wow, another fantastic talk by a true expert in the field. So I just have one, question to start off. Could you explain a little bit, how you technically handle the device when you're doing the VSD repair or any other sort of heart surgery. So the patient goes to the OR, they have the 5.5 in, it's across the aortic valve, it's 5 centimeters below the level of the annulus. What do you do when you have to put the cross clamp on and manipulate the heart? How do you handle the impella?
Yeah, good question, Marissa. So the impella is always in the axillary position, which makes it easy. Cross clamping is straightforward. Whenever you have an impella across the aortic valve and you cross clamp, you have to recognize that your myocardial protection with antegrade cardioplegia is not going to be effective. We always bicavally cannulate these patients, put a retrograde cannula in directly with the purse string in the coronary sinus, so we rely on retrograde cardioplegia. We typically pull the impella back a couple centimeters, but not past the aortic valve, and then do the repair. Majority of time, we don't even need the impella post-repair. Majority of the time, we can actually remove it pre-cross clamp. But if we do feel that we might need it, especially if it's not been that long since the placement, if it's been 7 days, 5 days, we may elect to leave it in place and wean it post-operatively. It's usually not a problem. Posterior basal VSD, you'll see it in the field, obviously, but if you're doing a anterior apical, you won't. It'll be too high up to see. Many of the times we can go without even a ventriculotomy, and we're actually doing this through the right atrium, through the tricuspid valve, potentially detaching the septal leaflet of the tricuspid valve to put a patch in. So there's many different options, and it becomes a different operation when you're doing this, and you can attest to this as well, Faisal, with this device.
I mean, it's a total game changer. I mean, thanks to you and contributions from many in this panel. I mean, I hate Swiss cheese, especially at 2 in the morning, It's not very appetizing. But I think you mentioned some key aspects. One, you put in the impella, it buys you time. It buys you time, the patient time, and the family time. Like, is he or she the kind of patient that's going to have quality of life? Are they robust enough? What was the baseline to start with? So you don't have to make an immediate decision to rush to the OR. As you wait, you reverse the physiologic derangement. So the liver function gets better, the kidneys get better, and then the tissues get better. Now, we used to think that, hey, it's nice to wait 6 weeks to get the scar tissue that will hold suture. But as you mentioned, we've got in, 2 to 3 weeks, and the tissues have been surprisingly nice. They actually hold the suture. And it's a total game changer to go through the right atrium. I mean, it's unimaginable, right? So I really think that this technology has been amazing, and this is a very timely topic, so thanks for discussing it.
So on these right atrial approaches, so you're patching from the right side?
Mm-hmm. Yes.
So you violate the dogma that you have to have the patch on the left side?
You violate the dogma. I mean, when you do Corner-Ross, when you do...
I don't do Corner-Ross.
Well...
I'm not good enough.
If anybody... When you do a root enlargement and go through the septum, you put the patch on the right side, not the left side. Because if you put it on the left side, you actually diminish the amount of outflow LVOT enlargement. So I think this is a myth that you need to put it on one side versus the other. Well, do you agree, Ed?
No, totally. So the reason for all of the infarct exclusion techniques and all these other techniques that have tried to exclude that septum was really because there was continued infarcting myocardium present. So you don't know how much of a bigger hole you're going to have in the next number of days because it was an acute repair. Now you have matured the infarct, and it is totally different. This is like doing, as all of you have done, a pseudoaneurysm repair, right? You do a pseudoaneurysm repair weeks after the actual rupture, and it is a defined hole. So it's actually quite nice. Sutures hold very well. So that's why Faisal's comment is it doesn't matter what side you put the patch on because you've got defined myocardium.
Thank you very much.
Ed, great talk as always. Really remarkable slides. I think this is such a great amalgamation of technology combined with just great clinical decision making, and really you've created a new paradigm. Towards that, do you feel like you've now kind of established what is that opportune time? Is there anything other than imaging that we can kind of tell this is the time to intervene? As Faisal talked about, of course, you want to clear all the metabolic derangements. But after that, are you finding what is that optimal time when the tissue you think is ready to hold sutures or a patch and that right-sided approach?
Yeah, that's a good question. I think we tend to overestimate the time, meaning we wait a little longer than we probably should. So that's going to be a question that we're going to need to look at all of these cases and try to understand that. I think there's a little bit of a...
Those 25 cases, what was median time to
about 16 or so days, 18 days, somewhere in that range. So I think we still have to define that. That's one area where I think a lot of more data, because these are not cases where each center can do 40 or 50 of these in the course of a year. We have to put our data together. We have to try to understand this as a group. So hopefully over the next year or so at meetings like this, we can share some best practices.
Two questions, Ed, and maybe to Marissa as well, because you're an LVAD surgeon. One of the big basic tenets of LVAD surgery, if you have a PFO, you close it. You're completely throwing that away. Because if you have and we saw it, you had a small hole in the left atrium and an interatrial septum, you put an LVAD, you can deoxygenate tremendously. Now you're telling us that a bigger VSD sitting in the ventricle as opposed to an interatrial septal defect does not shunt. I just don't understand the physiology. I think it's fascinating, but I don't know why.
Yeah.
Do either one of you close PFOs anymore?
Don't tell Dr. Naka, but I stopped closing the PFOs.
Do you close them?
No, I stopped closing the PFOs in bad patients.
Yeah, we've basically stopped that too. So it's interesting. One of our leading cardiologists at the Cleveland Clinic did not believe this, also felt that it would reverse the flow and deoxygenate, but it didn't. And it didn't again, and it didn't again. And when we looked at and did some bedside studies on all these patients with turning up the performance of the pump and looking at the SWAN hemodynamics, it became apparent that was not happening. So I don't know. That's
you have to play with the speed. I mean, can you go to P9 or it's?
Well, you don't need to go to P9.
Right.
You don't need to go to P9. But
I wonder if you put a P9, you start shunting more.
You'll start shunting a little bit, yeah. And you'll notice that with the PA pressure starting to come down. Yeah.
Now, this is great. So essentially, you're taking a patient who was hypoxic, coming in from the pulmonary overcirculation, and getting their lungs cleaned up with the VSD still unrepaired. So that's great. Well, I'll just move on to the final presentation by Dr. Reddy. Thank you, Dr. Soltes.
Well, great. You guys have heard some wonderful speakers. Marissa kind of laid out to you how high risk these patients are. You heard from Dan, a really amazing trial that's launching, and then, of course, this fascinating approach and paradigm-shifting approach that Dr. Soltes gave you. What I want to talk to you about just briefly is how many of you, just by show of hands, understand and have ERAS programs implemented at your centers? Just a handful, so this is good. So I want to talk a little bit about the strategies of what ERAS is and how it may work for this group of patients. Now, look who else is interested in ERAS these days. The thing is, if you type up, you go to Google, and if you Google ERAS, this is what's going to come up, the Taylor Swift Eras Tour, but you never know. So what are the components of ERAS? Of course, ERAS is enhanced recovery after surgery, regardless of what Taylor Swift says. And it's really comprised of these type of components. There's a patient engagement component, nutritional components, mobility, peri-op, fluid management, multimodal analgesia, and some best practices. And I want to go through a few of those with you rapidly, but more importantly, maybe just talk with you all about a way you could implement it or how it resonates with you. There are really three phases for enhanced recovery. There's a preoperative phase, there's a intraoperative phase, and then there's a postoperative phase. And in the preoperative phase, there's certain things you can do to optimize these patients, sick as they may be, just like you heard how the 5.5 Impella can optimize that VSR patient. There are other things you can do to optimize that patient as well. Don't forget, these patients are probably nutritionally depleted. They may be in various states of frailty. All of these things can be optimized while you wait. So what are some of the quick things I would recommend for even this complex high-risk pool of patients? Perioperative glycemic control is something you can very easily do that has huge impacts for infection reduction. And all of these patients are at risk for infection. And as you know, diabetes being the epidemic it is, many of these patients that come in have really deranged hemoglobin A1Cs and need to be optimized. So insulin infusions or whatever it takes, but the data shows to make an impact, you need 48 hours of optimized glycemic control. Glucose is under 200. Just that simple thing by having 2 days before you take them to the operating room with glucose is under 200 will result in better postoperative outcomes. This one is a little bit harder. Serum albumin, all of us know from decades ago, even from the VA studies when we were all residents and stuff, that you take, PPP, piss poor protoplasm to the operating room, you're going to get a really bad outcome. So this is a tough one to impact, though, because albumin is not something that bumps up rapidly, but nutritional support can be given to these patients, and there's a plethora of newer, advanced dietetic enhancements you can do, or enhanced carb-loaded drinks. Just talk with your nutritionist, but you'd be amazed how much you can do even in a short inpatient stay to optimize that patient. One simple thing, if any of you guys are going to go take a long run or a walk, you don't go do that dehydrated, right? Simple carb loading, something that marathon runners and others have known, top athletes, is something we don't do for our patients. We typically dehydrate them for anywhere from 12 to 24 hours, depending on when your case is scheduled, before you take them to the operating room. Something simple as 4 hours before going to the operating room, letting them hydrate with a carb-loaded drink can have substantial outcome differences in gut motility and recovery, regardless of the complexity of your patient. And then the other thing is patient engagement. Again, for this patient pool, particularly for VAD patients and others, you can't even start thinking about putting in durable mechanical circulatory support in patients without some sort of patient engagement and going through the whole social and psychological aspects of these patients. But I think very important to do. And then prehabilitation. Frailty is rampant. You always know, like a lot of doctors think, I know it when I see it, but you don't. There are people who are frail without you recognizing it, unless you make all your patients do the 5-meter walk test. If you keep one of those things in your pocket and you make them do a grip strength, you'd be amazed how many patients are going into surgery already frail, and how you can impact that in a very short period of time. So I think in summary what I'd say is there's a bundle of care practices that should be performed to reduce things like surgical site infection, which certainly these patients are at risk for, and these are all simple things that you all know about, but I think you have to put them together as a bundle with nasal decontamination, appropriate temperature control, the appropriate timing of antibiotics, so important, and then obviously blood product management, and consider things like rigid sternal fixation in the postoperative period, and really trying to prevent kidney injury is just so important for all these patients. So I think that's what the best practices is, how I'd summarize them, is think about multimodal analgesia. There's nothing worse for delirium than pounding patients with a lot of opioids. You create the problems that you have to then go back and tackle. I think really important to screen for delirium and then anticipate it and then prevent it. I think early extubation, we can all agree, is beneficial to patients, both in terms of reduction in ventilator-associated pneumonia, but also for patient comfort and family comfort. There's nothing more distressing to a family member than coming in and seeing an intubated patient days after surgery. There are some new biomarkers and tools available to us to help prevent acute kidney injury. But I really want to close out by something that again, when you talk about how technology can improve patient care, how this technology has really made things like early mobilization possible, which is another tenet of enhanced recovery after surgery. So what you see here is one of my patients from this past week. He's post-op day 1 from a direct aortic impellant, and really go to your point, Hen, about I got to experience this firsthand. So I tried to put it transaxillary in the operating room with a C-arm. I just could not get it through the vessel for whatever reason, even though he was a reasonably sized man. So then I shifted to a direct aortic strategy, which we're fairly comfortable with. This guy had a 12% EF, but on MRI, viable myocardium. Did a heart team discussion for several days before, optimized him as best we could, and the decision was really revascularization surgically because of the number of CTOs he had, a bio-MVR because of the non-clippable mitral anatomy was the best operation. And fortunately, he's doing well. I called and checked on him this morning. The only reason there was some delay in why he's in chair position on bed 2, you can't make this stuff up, but this guy actually has a BKO prosthesis, and the family misplaced it. So we'd been looking for it for a day, so then he's up and walking around now finally. But, you know, you think it can't happen until it happens, and then it happens. This patient is another really great example. I hope I can get the video to play. He's post-op day 2 after direct aortic impella, complex cabbage maze, PFO closure. What is it that you notice about this guy? He's smiling. That's exactly right. Patients are happy to ambulate, and they really feel like they're improving, that they're making progress, and the families see this progress. So I think the other important thing to recognize with this type of technology and the approaches that we can place this in is that you can really take your time weaning them, but while you do that, the enhanced recovery protocols can be completely in place, and you get happy patients walking down the hallways. Thank you very much.
Wow, that's a great talk, and I learned a lot from that. And we're trying to, you know, one question I had for you is, in terms of, you know, we know the value of getting patients out of bed, walking them around, minimizing all this stuff. How do you get some of the other providers that need to take care of these patients on the same page? Like, how do you get nursing staff comfortable? How do you get your ICU comfortable with getting these patients out of bed when they're so sick initially going into the operation?
It's a great question and a great point. I'll tell you this, I've also noticed it anecdotally, and I need to do it in a more prospective, measured way. When you mobilize these patients, their pressor requirements actually go down. So the paradigm shift in our unit was you can mobilize patients on inotropes and pressors, and that it's actually not detrimental to their health or well-being. And for whatever reason, after a walk, you sometimes find the pressors actually come down. In terms of the resources needed, you're absolutely right. So this is where you have to start partnering with your RTs for the early extubation, your PT and OT teams to all come together and figure out what's a safe way of doing it. We actually mobilize patients on VV ECMO, walking around, with femoral cannulas. So all of this can be done, but it takes a very thoughtful, coordinated approach.
That's great. And I guess one other question is did you partner with an ICU doc on this, or like how did you get buy-in when you started this process? And then have anyone here have any experience with getting the patients on the 5.5 out of the ICU to a step-down unit if they're on long-term support?
Up to your first question about, you know, and there is a session later today also a little bit more in-depth, and I noticed many people in the room do not have an enhanced recovery program in place. Come find out more this afternoon at 4 o'clock. But I will tell you, it's a team sport. Just like all of what we do is a team sport. You do have to put together champions in these areas and then implement it that way. Going to the second question about stepping up, we have not, I'm sure maybe some more advanced centers have done that. Our longer term Impella patients still stay in our intensive care unit, but that might be a good thing to look into.
Yeah, and I think, you know, as we look to the future of ERAS, I mean, some of the work that we're seeing with, and some of you have obviously done this, is using Impella support for high-risk cardiac surgery patients. I think we will see within the very near future these patients going to the step-down floor, having protocols in place for getting them out of the ICU. We know how important that is, obviously. So I think that we will certainly see that.
I'll tell you one thing that we don't do. We don't ambulate any patients with a balloon pump in.
Oh, they're axillary.
Yeah, that's true. We don't do a lot of those, but yeah, that's true.
We don't put our patients in a step down, but what we have done is got the CCU to take them. And that's a great addition because it frees up the surgical beds, particularly for you guys, Ed. So they're very comfortable. I think, Marissa, where you're going, the question with nursing, we find it sort of an uphill climb to get the nurses involved in this. They seem to think that most of the care they deliver should be medications and turning them. But when it gets to ambulation, nah, you got to get the physical therapies in there. So it's a culture that needs to be fought with, at least at our institution. And so you have to get buy-in from the head of the ICU, the nursing ICU, to try to help us with that. But I think it's a critical endeavor for sure.
Fantastic. Thank you for your comments, everybody. I just have one more kind of general question for the panel. When you're weaning, and this comes up often, like, how do you know when it's safe to get the device out? What do you use? Are you using echo? Are you using Swan? Do you have some just basic gut instinct, some gestalt about when it's time to take this device out? We can just start with Dr. Goldstein and go down the panel.
So multimodal. So we tend to drop the P's, right? So we start with whatever the P's is and try to come down to P2. We always have a Swan in because then allows you to provide the cardiac output input to the console so you can look what the CPO is. And if CPO is greater than 0.6, usually okay. We tend to leave dobutamine on. That's our favorite inotrope because then I have the hypotensive effects on milrinone. So dobutamine at 2 or 3 mics per minute. We get a bedside echo. You have the Swan numbers, and that's how we decide. You know, the ability to get a wedge, you don't want the wedge above 16. You don't want the CVP above 12. And you want a good cardiac output. So that's more or less how we do it. Ed, what do you do?
Yeah, similar, right? We drop our performance level by 1 or 2 every day. Typically, we're not starting out at a high performance level anyway after you know, high risk surgery with Impella Assist, maybe P6. And we try not to use echo as a guide because you're not going to see an improvement in ejection fraction. And don't be fooled, because if you wait for that, you're going to be waiting a very long time. So we use hemodynamics to look for stability of hemodynamics. And again, you know, what we're trying to achieve with all these is to mitigate that early hazard phase, which is typically, if you look at all the data, it's in the first 2 or 3 days where you see low cardiac output syndrome or post-cardiotomy shock develop. So as long as you can get by that phase of care, you typically are okay. So again, don't be fooled by an EF that's still 15%. It will be 15%. It's not going to, you know, it's not going to get any better immediately.
A couple of added tips I might throw in there. So a couple of things. Number one, it's just like your iPhone screen and like your radio. You have kind of a continuous level of adjustments you can make, everything, like you said, from P2 to P9, unlike with some other devices where there may be only 1 or 2 modes of weaning. Number two, I think you have to decide in your unit who's going to do the weaning. The worst thing that you have is everybody wants to play with that dial. So I think there's got to be some coordination of care. We have found in our unit that's very important. Number two is, as you pointed out, Dan, is with what we like is a margin of safety. We like the inotropes down to very low levels to where when we take the device out, you have somewhere to go. And number two, we usually give them on the day that we think it's ready to come out, we usually have it at P2 and let it give them 1 more day. And then we have a real margin of safety is what we feel like. I agree completely with Ed. You check echoes mostly for positioning. You sometimes see recovery, sometimes you don't, but that doesn't really need to be the director of when it's ready to come out.
Okay, great.
Echo helps see the right ventricle. That's where I find the echoes helpful. Is because sometimes the right ventricle is what actually ends up hurting you, and you end up in the OR trying to take it out. So I just found that sometimes the echo helps you see the right ventricle, and then it's going to be okay too. I don't know your opinion on that.
I don't think you get very good windows postoperatively on an RV, number one. Number two, if the CVP is 8, I don't care what the RV looks like. And we learn in the LVAD world that echoes post-op are useless for RV function in general.
I would agree. Use PAPI.
Yeah, the echo, well, we use the echo as the issue of MR. Because there's a lot of MR. You start a little worried the patient's not ready. So that's what bothers us. And the other thing that you should always do is engage the heart failure cardiology team. Yep. They should be rounding with you every day, and we do this every day on every patient that has any support. Because GDMT is critical. It's part of the IMPACT trial, by the way. Because they know how to manipulate diuretics better than you can. They know how to afterload reduce better than you can. And they can help us with all these things better than you can, particularly when you're in the operating room. So,
I would add one other thing, is implant technique is important. So if you're putting it in axillary, we would argue that you should not be tunneling, because tunneling leaves a long graft. That long graft, as you know, has those corrugations on it, and it's going to move. And movement leads to hemolysis. So if you leave the graft short, you don't tunnel, a couple centimeters, all underneath the skin, the device will not move. You will not have, we really have not seen hemolysis. You see hemolysis with the CP because it comes from the groin, and literally a 5-degree movement of the patient in bed is going to translate to a couple, 2 or 3 centimeter movement of the device because of the length, right? So it's just the inherent nature of the anatomy dictates its stability.
I think when talking about weaning from MCS, besides monitoring, it's also important to talk about optimization of the hemodynamics. So what is very helpful in our experience is to start with levosimendan 1 to 2 days before the planned explantation date. So do you have a comment? What is your experience regarding optimization of hemodynamics? Any drugs that you prefer?
You mean as we wean?
Yeah, for weaning.
Yes, that was my comment regarding the heart failure team being involved. So sometimes they can add GDMT before, they know how to use Entresto. They know how to use these drugs better than we can. We always leave dobutamine just to have a little backup. And every patient is swanned. So you're checking wedges, right? If the wedge is less than 16, you're pretty happy. So that's how we handle it. I think every ECMO patient should have a swan.
Thank you.
What do you guys practice?
I completely agree.
We did. Same.
I mean, there's so many questions that we could keep talking, but I just wanted to ask the panel's thoughts on the position in terms of, okay, it has to be a certain depth. It can't be too shallow. It can't be too deep. But does it matter if it's flipped kind of one way versus the other? We get these echoes. The cardiologist might say the impella is not positioned appropriately. Do you see any difference in the performance, or are you trying rotating the device once it's in place?
We try to do all of that at the time of implant.
Sure,
it's very difficult to do afterwards, but I do think it's, we really do prefer with the elbow, just facing with the device facing towards the apex and without interference to the mitral apparatus.
Yeah,
Terrific session, guys. Quick question. Any experience with using Impella in low EF for off-pump bypass?
No, but I know there's interest, and I know there's a trial going on, if I'm not mistaken. Is the Abiomed team here? Sanjeev? Question from John. Off-pump cabbage with Impella support.
I think the German guy said
Yeah. Yeah. Just thinking about the maintaining the optimal position of the tip in the ventricle. We got a lot of different rotations and maneuvers, right? We don't want to cause endocardial damage or perforation, God forbid. But on the other hand, it seems like an ideal device to support the really vulnerable ventricle for a short time during an OPCAB case.
Yeah, I think our colleague from Germany has some experience. And then after the initial session earlier today, a Japanese surgeon told me about his series of 12 patients that he's done using the Impella. IMCAB is how he's describing it. Here we are.
There it is.
Excellent. From the source itself.
While he's coming to the mic, Dr. Puskas, your trainee, Dr. Wen, and my colleague has performed a couple of those as well.
Maybe I can briefly comment on your question, Dr. Puskas. We've done a couple of cases with Impella OPCAB, and we have very good results. It's not a problem of positioning. It's not a problem of dislocation during exposition of the heart. So it works, right axillary approach. It works very well. 5.5. It's great for unloading during the operation to bring down the stress to the heart intraoperatively. I think it's a very promising approach to go for minimized aortic manipulation and postoperative support.
Do you worry about it?
Actually, we had a median duration on the intensive care of 5 days with the Impella pump. Then you can go for very gentle weaning from Impella.
Yeah, I'll add also that our interventional cardiologists who do high-risk PCI in low EF cases prefer to have not a CP Impella for just the duration of the case, but a left axillary, because they go right radial, left axillary Impella 5.5 for about 2 to 3 days, even with the. You put those in there. Yeah.
Is it okay? So we've been using this way. It's called INCAP. We made a word. So about 12 cases so far. So for 3 years. So, but indication is very important. We need to have a very big heart. Otherwise, when we lift up the heart, so then lots of alarm occurs. So that, and then especially they are moving the heart, like a lateral the anastomosis. That is a very difficult part. I mean, it's easy compared to the just usual op pump, but the positioning during the lifting the heart. So the transesophageal echo is very important, and also the anesthesiologist. So when the alarm starting the ringing, and then we have to go down to like a P2, P3. So those are the kind of the tips to perform this procedure. But the impeller is really ideal to perform the open CABG.
Do you worry about AI at all when you have the impeller in and you are manipulating the heart? Have you seen a lot of AI with the manipulation, making the LVOT, making the aortic valve even more incompetent?
Yeah, that's actually the AI is not so much the issue during the op-cap, I mean in-cap.
Have you had any trouble with trying to get getting the side biter on? I've done several cases where there's been an impeller in place. We've done urgent cases on the pump, but I've found sometimes that impeller is right where you're trying to get the side biter on and trying to push it out of the way. Do you have a hint for that?
Oh yeah, that's the point. So also the transesophageal echo can tell where the impeller. So usually the impeller is actually behind the aorta. So it's not so difficult to use the side biting clamp. But we tend to use a sealing the device like a heartstring. So that's much easier to do this procedure.
Okay, well,
John, one more question.
I could see you're about to close. I just wanted to, thank you folks for doing a great symposium here at lunch. I think this is a very important area for us to explore as we try to improve the quality of surgical care of the coronary patient, especially the really sick surgical coronary patient. So well done, and thanks to Abiomed and Impella for supporting this. This is really key. Finally, we have this terrific opportunity to engage in a hands-on training session in the so-called Training Academy next door. There's a 90-minute block beginning now, and then another one beginning at 3:30. We'd love for you folks just to head on down there and enjoy that as part of the offerings of the curriculum this year. Thank you.